you. So I was assigned the topic of the evolution of MIS TLIF, and I thought about this for about a month as I was preparing, because this is quite the audience, right? And I thought, well, what am I going to talk about in terms of the evolution? So here are my disclosures, and I think a lot about evolution from the perspective of biology, right? So what does that really mean, right? So when you look at evolution, it means that there is creation of new types of organisms, if you will, or in this case, procedures, but there's also the destruction of others. And so evolution and obsolescence go hand in hand, right? It's kind of like bone formation. You have to break down bone to make new bone. And so, and I'm a neurosurgeon, so if I can say that, then maybe I'm inaccurate. But the point of the matter is that you have to be willing to break apart some of the past patterns of behavior and thought and science to get the new ones. Now, this is a picture of one of our Infolded fellows, Greg Basil. And I always tell the fellows and residents, if you really are dedicated to spine, you will dream about the spine. You will go to sleep and you will wake up thinking about the spine primarily. And I do that. I think about it. And I've been thinking about this, much like many of you out there, for several decades now, wondering about what the nightmares are and what the dream sequences are in terms of what we're going to do. And TLIF plays very well into this. So if we were to look at the evolution of humans, right? So here is the genus Homo tree, right? Starting with habilis and erectus, all the way up to sapiens, and then there's Neanderthal and Florensis. And this is constantly being modified, right? This is a very exciting area. I studied anthropology for a bit at Stanford. I really enjoy this element of looking at where we come from. So we could talk about, say, like Homo habilis being like the early spinal fusion. This would be like, you know, the old Hibbs procedure and all that kind of stuff, like the granny fusions. And then you got to this era like of standing upright and maybe using some more tools, and that's like instrumented fusion, right? And then interbody fusion, right? This is a very important branch point, because to me, interbody fusion is almost by definition the genesis of minimally invasive fusion. At least for now, right? That's not always going to be the case, but up until now. And then you have things like these sort of like, I don't want to call them dead ends, but like posterolateral fusion type things that are, let's just say they're getting a little bit dated. And then I would say like MIS interbody fusion, whether it be TLIF or XLIF or DLIF or OLIF, would fall into this sort of very, very excellent category. And I'm going to offend my first group of listeners right now. And something like maybe cortical fixation is here, like maybe it's a dead end, like a Neanderthal. I don't know, but you know, we have a little bit of Neanderthal DNA in us, just like I do the occasional cortical fix, right? But it's not common. So this kind of gives you a layout of where we are. And so you can see that the major drive is towards this MIS interbody fusion. Now, this, of course, is Jürgen Harms' seminal paper talking about the invention, if you will, of the TLIF or TPLIF, and it brought about this whole generation of surgeons. Many of you have only known this generation, but when I was in training, the TLIF was a new procedure. It happened after I finished my training, so I got to see this play out. And the open TLIF really led to, like, it was like a rebirth of interbody fusion. It brought all that stuff with Paul Lin's PLIF, right, back into the mainstream. In other words, people are doing more interbody fusion. It was robust. It's easily taught. There were less cases of neuropraxia, because the rates of neuropraxia with a PLIF is something like 3 to 6%. But there were also some drawbacks, like the morbidity of the posterior exposure, the pain, the complications were similar, even if they were reduced in rate, right? But you can't argue with the results. This is a slide and graph showing the trends in what happened at that time. And what you see is that the growth of spine fusion really being the growth of interbody fusion. Now, this has played out in successive generations for almost 20 years now, with the rebirth, if you will, of the lateral approach, for example. And so you can see posterolateral, instrumented, uninstrumented fusions steady or declining, and interbody fusion increasing. So this is very important to pay homage to, because it is part of the genesis of MIS, right? But then we had the entry of the MIS TLIF. And again, I will apologize. I don't know the whole audience that's watching, so I'm going to try to offer up a little bit for every category, whether you're foreign or in training or not initiated, all the way up to people who are very advanced. So I apologize if this goes a little slow, but you'll see why I go through this process.
Wait, Mike, we can let you know real quick. So we surveyed the virtual spine audience. And Jonathan, correct me if my numbers are wrong, but it's about a quarter from the US, so 3/4 from elsewhere, mostly
nice.
Middle East, South America, And I think it's about 75% attendings and 25% trainees.
Oh, okay, good. So a lot of foreign attendings, I should say.
A ton.
Excellent. Thank you, Coy. Thank you for that. So, obviously the advantage of this is it allowed you to do the decompression, the fixation, cage placement, all that, and all with supposedly less pain, blood loss, and complications, right? So we all know this, right? Now, I'm going to walk through this because not everybody does MIS TLIF. Maybe we can, are you guys able to do like polls or hands up or something like that? So I will bet that not everybody out there is doing MIS TLIF. So I'm just going to walk through it real quick. And I like this. This is homage to Roger Hartle because he does these things like 10 steps of. So I'm just going to go through it very quickly, right? So this is the positioning. In the MIS procedures, positioning is more important because in an open procedure, I'll be honest with you, I'll just go to my office while they position and intubate and expose, and I'll come back and do the meat of the surgery, then leave and they'll close, right? Very, very efficient for me as an attending with fellows and residents. But in MIS surgery, I got to be there for position. You can see right here, bolsters in the way, all kinds of equipment that is added, right? That you need to see. This is a typical OR setup. I think it's not a bad idea if you don't do these procedures to get an idea of how you're going to set things up because there's all this equipment, right? And this is a very common question about planning incisions, right? And this is kind of how I like to do it. I don't like to have hard numbers because I think it depends on the type of patient that you're going to be treating in terms of where you're going to be going. And then what I do with an MIS TLIF, and I have, by the way, 4 different kinds of MIS TLIF, but we're not going to go into all of them, is this Wiltse plane dissection. So we combine the Wiltse plane between a longissimus muscle and multifidus muscles. So there's almost no bleeding. I don't just take a tube and shove it through and dilate up the muscles. I like to use that Wiltse plane. And this is a homage to the late Leon Wiltse, who used to run Rancho Los Amigos in Los Angeles and had a great orthopedic spine fellowship. So then you expand your retractor, you place your retractors. Now, I'm going to make the first commentary about this MIS TLIF procedure. What do you think? And maybe you guys can chime in on chat. What is your typical tube size for MIS TLIF? And I will tell you that my first MIS TLIFs were done, they were actually MIS PLIFs through 14 and 16 tubes because there was nothing else. But I'm guessing it's going to be somewhere in the mid-20s. So 22, 24, 26. Now you can argue if that's truly MIS, right? Tubular access lets you get in the Kambin's triangle or drill through and get an interlaminar approach, right? And this is a classic drawing. This is actually not necessarily a true TLIF. This is a T-PLIF. If you start with the dura and work your way out, medial to lateral, that's actually a unilateral PLIF. If you start from the outside in, that's a true TLIF, meaning transforaminal, right? And so there you see, we actually see very little of the neural elements unless we want to in terms of this approach. And then discectomy, this is a nice CT showing a cage misplaced by a very, very famous spine surgeon who will remain unnamed. I have plenty of complications. I'm not throwing arrows or bricks. And then dealing with the end plates and getting things like, how do you cut the end plates? Do you not cut the end plates? Cage geometry started to become an issue because retraction, getting interbody height. So all these little things.
Mike, sorry, I'm going to interrupt. This is Ali. Can you go back a couple of slides?
Yeah.
Because I think that's an important point to the cage that is obviously.
Yeah, let's go back to that.
Yeah, if you don't mind, because that way you can also share your experience with our audience. So how do you avoid that? Let's say you're doing an MIS TLIF. How do you avoid that? Is it fluoro? Is it navigation? Is it experience? Because you just said, I don't know who did this, but you said this was an experienced surgeon. What is your advice to perhaps some of the junior surgeons or trainees on how to avoid misplacing an interbody cage using a minimally invasive technique?
So I'm glad you bring that up. I didn't want to rush through it, but the point is this is a surgery by one of the most famous MIS surgeons in the world. If I were to tell you the name, every single person listening knows this person. It's not an indictment. I have cases like this too, and I put it up there partly to show that this happens to all of us. And let me just, for the people who don't do this procedure, my first MIS TLIF took 11 hours, okay? So that was back in 2001. So with this, I think that one of the very, very important issues is if you don't like to use a lot of x-ray, like in China, they don't. The handedness bias is so strong that that's what happens. So in other words, if you're operating on the lordosis of the spine, L4, 5, L5, S1, typically, there's going to be an angulation, right? There's like a Ferguson view angle. If you're operating from the right side, it's real easy if you're right-handed because you'll tend to shoot towards the caudal aspect. If you come from the left side, you'll tend to go towards the head. Now, you don't always get to pick which side, but if all other things being equal, you have to respect that bias. I have actually had fellows who've been off by 2 levels because of this. I'm like, Dude, you're at the wrong level. It's crazy because the handedness bias is so strong in MIS unless you consciously avoid it. Meaning if you're right-handed, you go to the left. If you're left-handed, you go to the right. And this, I was just ripping apart one of our fellows today about this. It is such a strong bias. And you could use X-ray or navigation to get around it, right? What do you do, Ali?
Yeah, I mean, so for us, we've basically, again, thanks to Dr. Hartle and some of the folks here, our MIS lumbar work is completely navigated. And we don't wear lead anymore. And for me, it took me a while to get used to, because as you know, I trained with Wang, which is, you know, X-ray heavy. And it took me a while, but now with the navigation, I think it helped a lot. But it does not take away from your knowledge of the anatomy or where the pars is, where the facet is, where you expect to find the disc. We use navigation as an adjunct to what we're going to do, not to drive the surgery, but it's all CT-guided navigation.
You might even learn faster, right? Because you have this constant feedback with 3D imaging. And I'll bet you if you were to map the brains of these people, I'm a spine surgeon, but if you were to map the brains of people who use fluoro versus nav, they're going to be different. So that's a really good point. We don't use a lot of navigation here. And there's reasons for that we can go into. So self-distracting cages, now we've got self-expanding cages, if you will, bulleted tips, all these things are important. This is very basic stuff. Again, understanding your international audience doesn't always have all the products we have in America, right? All the wonderful products we have. This is a classic example, spondy being corrected, nothing surprising about that. Cage should cross the midline, all these basic principles. Then the pedicle screws, and in Miami, we took on AP pedicle cannulation with the fluoroscope early on because we'll run up to 13 rooms a day. So we're not going to have 13 nav systems or 13 robots or whatever. We have lots of them, but not that many. So we try to teach the residents everything. And so the AP cannulation, how do you hit the mark? This is a very straightforward way for those who haven't done it. Line it up perfectly on AP view, end plates flat, spinous process in the middle, super simple. All you got to do is, you go in the bone 2 centimeters without passing the medial wall, and you're good. And this is the technique we use in the complex spinal deformities to try to minimize pedicle screw breaches. So with that, that's the technique. What are the effects? So this is a nice meta-analysis by Kevin Foley looking at 30 papers out of almost 1,000 on MIS TLIF. And this forest plot will show you that there's less pain with MIS surgery. This shows it favoring it. How about earlier normalization of life? These 3 papers by Odagwa and 2 by Parker show that people who have MIS surgery get back to work and play earlier. And this is important. So this has been proven, right? We looked at infections. The infection rate is much lower in terms of MIS surgeries. Frequently, MIS surgeons will say they never get an infection. I don't believe that. I think maybe, you haven't done enough surgery, but it's certainly a lot less than the 2 or 3% that's typical. CSF leakage reduced, right? Why? We're not seeing as much dura. We're not seeing the whole fecal sac in every case, right? So that's natural. Reduced narcotics. This is important in the opiate epidemic crisis, right? A lot less narcotic consumption in terms of what we do with them and getting them back to a normal life, right? So that's sort of the very introductory stuff. And it brings up this question, does a tube equal MIS? And when I finished fellowship, there was this era of tubology. And it was like, as Larry Koo used to say, look what I did through the tube, Mom. And there was a paper about everything done through the tube, spinal cord stimulator, synovial cyst. Whatever you did through the tube was a new technique. But is a tube equal to MIS? And the answer, of course, is no, right? And I also want to, because I wasn't assigned this topic, pay homage to all the other access corridors that are out there, because they're very important. And I know you've had webinars on this already. O-LIF, A-LIF, X-LIF, D-LIF, transsacral approaches, all this stuff are very exciting. But why do I like TLIF? So I'm constantly debating guys like Luis Pimenta, right? Why? Because look, there are some real risks with anterior approaches. This is a arterial or vascular injury here. This is a screw extrusion. Things like thigh pain that we published on with lateral approaches. These are not insignificant. That doesn't mean these procedures aren't good. It just means they're different, right? So what about the MIS TLIF? So let's go back to this. We talked about open TLIF. So MIS TLIF, widely applicable, well understood, demonstrated efficacy, properly reimbursed, allows both direct and indirect decompression, of course, fusion, instrumentation, all that. So it's got the whole bag of tricks. But there are some major issues with MIS TLIF. It's hard to learn and replicate, right? The advantages of open surgery are incremental. In my data, when I looked at open versus MIS TLIF, the difference in length of stay was 1.2 days. That's incremental. It's not transformative, right? It's not standardized. I'll bet you none of the faculty, none of our experts on this panel do an MIS TLIF even remotely similarly. We've already heard, Ali, you use NAV. How about you guys? How about Coy and Griffin and John and Jonathan? What do you guys use in terms of how you put your screws in? Is it all different?
Yeah, so that's a great point in question. So since coming to Duke, I've started putting in my screws with the robot. And then on the more symptomatic side, docking a tube in between the screw heads, and then doing the facetectomy, discectomy, and interbody work that way. What about you guys?
How about Griffin? Griffin, what do you do?
So we use a lot of navigation here. So we've got a couple of the Stryker navigation systems, which have all been upgraded. Our biggest improvement, no question, has been getting one of the Zeem 3D C arms. We had an old ISO C that was about 10 years old, but I think really like Ali was mentioning, the rate limiting step for a lot of these navigation based systems is the image acquisition, no question. And I think that goes for robotics as well. I used the robot extensively last year with Ron Lehman. That's always the rate limiting step is, getting your reference scan, but that's what we use.
How about Jonathan and John?
They're very nav heavy at the clinic. We have the O arm, so we bring that in, get the scan, then they bring the self in, register the patient. It really is it can really be quite a production at times. And if the tech, there's certain different techs on different days of the week. If we have one that's a little bit, gets preoccupied or can take some time, it really, really can mess up the workflow of the case. So we're nav heavy, but we also use it sparingly.
And John Shin?
Yeah, Mike, we use primarily navigation now for placing the screws. When I started off, we used fluoro, but now we don't have a robot yet in Boston, so but use navigation.
So just with the 6 of us, I've heard Zeem, BrainLab, Stealth Trion or whatever, robot. I use AP only. So just with 5 people or 6 people, you've got a plethora of techniques, right? So, I've been talking a lot about this cost of surgery, and this is the nightmare part of that, dreaming about spine. And I'm very worried about this issue. And cost, by the way, can be counted financially, socially, economically, health-wise. There's a lot of ways to think about cost. What we do know is when we do a fusion, there's a cost of the surgery. And so when we look at a patient, right, you have an inciting event, they get worsened and better and with all these conservative treatments, then guess what? They have a surgery and typically their pain increases, right? So I'm not talking about a microdisc or something super simple. And in this time period, there is suffering. And that's when people are, in the hospital getting narcotics and all of this, right? So you could call that like an open TLIF type of curve. Now, let's say we bend this down. We might be able to bend it down with MIS TLIF and get an appreciable return on our investment of effort, right? So that's been the trend lately. But what if we were to go really, really MIS to get this down to background? And that's what we've been trying for the past 2 decades here in Miami. And let me just add to this, and I don't know where everybody's from, but in the United States, I have this nightmare about the existential threats to spine surgery, okay? Just like the dinosaurs. So right now, spine surgeons are the highest paid doctors in America. We are the apex predators. We are T-Rex, okay, or Allosaurus, right? We are the most susceptible to any little ripple effect, and we are seeing it right now with coronavirus. So patients are terrified of us. They're more terrified. The only people that rank with us are probably dentists, right? People are terrified of spine surgery. Everybody's heard don't ever have spine surgery. They know that they're negative sequelae of our interventions. But there's an incredible demand for services. This is the irony, right? So people are terrified of you, but yet your waiting list is at least before coronavirus was like hundreds or thousands of patients deep, and it's very expensive. And now with coronavirus, we're seeing exactly the razor's edge for us. Okay, this is not unimportant, and I'm going to get to that in a second, right? So how do we get more efficient and smaller? So I always think of myself as being a little rodent marsupial mammal. And then there's in the back here's this is like a Larry Lanky, like a T-Rex, right? Like not to be fooled with, but I'm just like a little squirrel over here, right? So how do we get smaller? And when I first started talking about this, people really would turn their nose up at it. They're like, you know, you're stupid. That's not how you get RVUs, dude, right? That kind of stuff. And so, you know, I stuck with it. And we built up our ERAS system, and many of you have heard me talk about this, the endoscopic plus the awake anesthesia plus the perc fixation plus the Expandable plus the expandables plus the BMP, which is off-label, and putting this all together. And I'm not going to bore people with videos of how well these people do, because it is crazy. It is absolutely crazy. And this is showing you, well, people say, well, why is it not a perc fusion? Or is it an endoscopic fusion? Or is it an awake fusion? Or is it ERAS fusion? It's all of those pieces. And you can see these views through the endoscope. You can see how beautifully the end plate's prepared to bleeding, the cartilaginous end plate mostly removed. So you can really get, and I can tell you the tricks and pearls if people want to ask, why does this work when the French tried this years ago and it failed, right? And I can tell you what the lessons we learned that were hard fought. This is data. You can look it up. You don't need me to spend your Thursday night while you're having a nice glass of wine talking about my data. Go look it up. It's out there. It's not perfect. We did our 263rd case last week. We have more this week, and I'm going to get to that. But this is a case I like to show. This is an example of a patient who has an ejection fraction of 11%. Okay, that's a no-go. That's a no-fly in almost any hospital. He's 86, grade 2 spondy. I'm operating on him. You can see he's got pacer pads on because they think his heart's going to stop. It's not going to stop. Why? I tell my patients, and it's not to say it's all better. If you have dental work, and dentists do hundreds of millions of procedures a year in America, they almost never hurt anybody. You know why? If you don't like it, you close your mouth, right? As soon as you go to an oral surgeon, now I know oral surgeons do bigger stuff. I got that. But as soon as they put you under, those people come out with trigeminal pain, with inferior pain, malocclusion, all these things, because it's a different situation. Now, why am I telling you this? I'm telling you this because we are about to enter an era with coronavirus where it's going to get hideous. Lots of your patients are going to have died, so they're never going to have surgery with you. Some will never come see you. Some will never come to the hospital. Some will lose their jobs and insurance, right? Let's just say you eliminated 20% of the viable patient candidates out there. For years, everybody said, Mike Wang, I don't need to hear your bullshit, okay? I'm the best surgeon in town. I'm like, that's fine, dude. I'm not here to compete with you. But when the meteors hit or the diarrhea strikes, the selective advantage will go to those people who can do things that are more efficient, right? And I'll explain that to you in a second here. The power of endoscopy, for those of you in the Midwest or parts of the country or world where people are fat, I don't care if the patient's 500 pounds. Makes no difference to me when I do these surgeries, except of course, going prone. That's a consideration, but I don't have to cut them open, so it doesn't really matter. Let me show you a case, just to give you an example. And I'm not trying to say these are the rare cases, so you have to follow it. These are the cases that prove it's different, okay? Here's a lady, 69 years old. She's from the Midwest. Classic symptoms of neurogenic claudication. What would be your treatment of choice? She can't walk, okay? And she gets laminectomy. Very, very legit surgery. No fusion, no screws, very straightforward, boring surgery, right? By one of the most famous spine surgeons in America. And it was done effectively, but they got a little dural tear, okay? Now, I'm going to show you something a little horrific I hope you never see, but you may have heard of. On post-op day 1, she's found obtunded in her room and hemiplegic. They scan her brain and she's got this, okay? So you know this is a potential consequence, rare as it might be, of a dural tear, okay? She goes on to be in the ICU for about 2 months. There's about 70 CT scans in her medical record. And she's blind in one eye and she eventually can walk and all that. And she's actually recovered much better. She can kind of get along, right? And she almost looks normal. So she comes down to Miami because she can't take the cold anymore, the Midwest, and she's got intractable pain from entrapment, top-down stenosis. Sorry, we can't show you every slice. Take my word for it. She's got top-down stenosis now. Okay, who is ready to take this person back to surgery? Well, I can tell you, if one of the best surgeons in America got a dural tear and she got a subdural, I'm not sure I want to go in there. So this is what she looks like, okay? Awake fusion.
I think we should, well, there you go. You beat me to it. We were going to ask the audience.
Oh, sorry, Ali.
That's okay.
Because you would have done a lateral, right? You could have done a lateral.
We were going to ask the audience what they would have done.
Yeah.
But just a question, because we're going to have, and I'm sorry, we should have touched upon this earlier, a couple of very good questions from the audience about the, you mentioned the pros and cons of MIS TLIF. And somebody asked about the fusion rate between an open TLIF and MIS TLIF, and now, of course, your endoscopic TLIF. Can you comment on those, the fusion rates among the three types or styles of interbody work?
Yeah, I can tell you from our data. I can tell you what the data are. Now, remember that we use BMP in Miami, right? So we're stacking the deck, right? So if you take a 1 level or 2 level, it doesn't really matter. Open TLIF, symptomatic pseudoarthrosis, because I generally try to follow my patients for life. I get very upset if they go anywhere else because I want to know if they have a problem, right? It's my clinic's super painful because, you know, having operated on 6,000 people, you're only getting the problems now, right? Because it's almost like an annuity. But I want to see what's going on because I'm observing the biology. My symptomatic non-union rate on an open TLIF is about 1 or 2%. Okay, it's pretty low. Remember, we're using BMP, right? On a MIS TLIF, it's about 2%. And on an awake TLIF, it's about 2%. And I'll tell you why. We were actually most concerned about delayed non-unions. When we started doing this, like, there's no way we can prepare the end plate properly. They're not getting any posterolateral fusion. We're not destroying the facet. We're not doing any of those pieces. How is it possible? Now, I'm not saying this is all better, because the one thing we have seen more of is early cage migration. So we've had a handful of cases out of 260 with early cage. That's not a non-union. That's like post-op day 15 or 20, the cage pops out, right? And I can go into why that happens and how we dealt with that problem, by the way, because I don't want other people to make my mistakes, right? But we believe that it's because we're preserving the soft tissue envelope. And please stop me at any point. But Ali, when Juan and I put our data together, we were talking about MIS deformity. We instrument up to T10, T9, T11, T7, right? I put BMP in the facets. He doesn't even put in anything. And our non-union rate on that and our follow-ups, like 10, 11 years, is really low. And I think it's because we're preserving so much of the normal anatomy. I think that's why, but I can't tell you for sure.
Yeah, no, that's interesting. I think the technique, but also the biologic of choice would be interesting. I'll also throw this out to the audience, which is, you know, how many folks use, you know, a biologic like BMP and interbody fusion? I'd be interested in knowing how many people do that and how many don't. But while they answer that, Mike, another great question from the audience. As far as trying to get either focal or regional deformity correction with, say, MIS TLIF versus even endoscopic TLIF, you know, in open, you want to do the bilateral facetectomies, get the grade, you know, reduce the grade 2 spondies. How are you handling patients that need focal deformity correction or listhesis reduction with this technique?
Yeah, so again, we're in the awake method, right? In endoscopic percutaneous awake method, you're almost 100% relying on interbody distraction. A little bit of positioning, but it's really interbody distraction. MIS TLIF is much more powerful. You can take the facet out. You can really get some spreaders in there and do things like that. Open TLIF is totally different. You can manipulate the screws and all that. Using the not awake method, but using the MIS TLIF method, we published our results with MIS TLIF for deformity. It's the cover article of JNS Spine about 8 years ago. And, you know, it works well for any coronal curve under about 48 or 50 degrees. And it works well with the fractional curve too. You can get a mild sagittal balance recorrection. You can probably bring the SVA back about 4 to 5 centimeters at the most. So you can't really get to the hard deformities. But it does work in the right cases, and it's much less traumatic.
Got it. Thank you. That was very helpful. I mean, I think as expected, several folks in the audience, and I think, I don't know what my colleagues here, I'll actually go ahead and ask them, Coy, John, Griffin, Jonathan, about using BMP and interbody for interbody fusion. You know, it's not standard. Certainly, it's not standard for me or our group. What do you guys do? Coy, I'll start with you since you're here on my screen.
Yeah, for sure. You know, MIS TLIF, the tubular kind, the kind Mike doesn't like anymore, is probably the most common primary case that I do. I can tell you I don't use BMP. I use a different biologic that's a little less expensive and perhaps has a lesser complication profile. I can tell you, now in my 5th year of practice, I think I've had about 1 pseudoarthrosis. So I've had pretty good results and hopefully, you know, save the institution some money.
John Shen, what's your take on BMP for interbody arthrodesis?
Yeah, I think, with an MIS approach, with a limited kind of exposure to bone and access, I mean, I use BMP as well. I think for open cases, for deformity cases, I try to use as much iliac crest and local autograft, but for MIS approaches, interbody space, I'll use BMP.
That's interesting. Griffin?
So I think an important piece of context about my practice is I did my residency training at Emory, where, as you know, Scott Bowden did all the preclinical work for BMP in his lab. And we used a lot of BMP in residency in my training. And even to Coy's horror and disgust, we would put BMP in peak cages and then put it in the anterior cervical spine. At this point, you should be like passing out, falling over from just disgust. But then I went and did my fellowship with Larry Lanke, who probably is the largest orthopedic utilizer of BMP. So I have a lot of experience using BMP. I actually, have only seen one of the, super crazy feared complications. Otherwise, I think when dosed appropriately, it can be very effective. So I do use it. I use it in my MIS TLIFs. I do use it in my open deformities as well. I do not use it in the anterior cervical spine, though. Despite having spent some time with Dan Rue, who still does it as well. So that's my long answer to your short question.
Yeah, no, that's important. Jonathan?
It's really attending dependent. At Mount Sinai, where I did my residency, we were pretty BMP heavy for new TLIFs, either open or MIS, with a little bit more of a bias towards MIS. And that's not so much the case over at the Cleveland Clinic. They're very sparing in terms of their use of BMP. For revision cases, and in particular, basically the big spine wax with major thoracolumbar revision cases, we tend to be pretty BMP generous.
Got it. Thanks, guys. Mike, I'm sorry, I know we held you up here. Just one last question. What's for your interbody BMP use? What dose do you use?
Yeah, that's a great question. So if I'm doing MIS TLIF of any sort, it's 2.1 milligrams per level. So extra small kit per level.
Great. Thanks so much. Okay, we've held you up. Thanks so much.
No, not at all. Stop me anytime. So half the on-label use dose for ALIF. And so to the question about deformity, we have started our foray into MIS deformity with this technique. And I will tell you, I'll just spill the beans. For sagittal imbalance and whatnot, we heavily leverage the ALIF. We basically, you can't really correct a deformity with just an ALIF. But if you could just do an ALIF, plus you could do 4 levels of fusion with this, you can get a pretty darn good correction. So anyways, more on that in the future. So now to the political piece. So switching gears, this is information that was released, excuse me, Popeye's Fried Chicken. This is information released in America by the Trump administration for the phased approach of reopening. Now, I'm gathering that you'll have fewer and fewer participants with every week, right? Because people are getting back to work. And this is not unimportant because this is like the canary in the coal mine. So this was released in April 16th. This is quite interesting. This is phase 1. And many of you are in phase 1 and going into phase 2 soon. And I'm going to just show you this right here, okay? This is a statement about elective surgeries. And if you can't read it, it says elective surgeries can resume as clinically appropriate on an outpatient basis. Now, I think this is the first and last time I will see us as surgeons or anything like this ever released on a national stage by the administration of the president. This is a major statement that this makes it up with like movie theaters and sporting events and visiting people and schools. I mean, that is a big statement. So if you have more than 2 neurons firing, you see where this is headed because the die is cast by the coronavirus. So here's the issue now. Patients are afraid of coming to the hospital. The economy may collapse. It probably will into a protracted recession. I saw yesterday, actually on Sunday, 40% of Georgians are unemployed now, 40%, 40, or claiming unemployment. There's going to be a bigger push ever for single payer Medicare for all. What's that going to mean for you? The number of privately insured patients is shrinking by about 25% already. That's just up till now because they lost their jobs. Insurance companies are going to have carte blanche to deny your surgery. They're dealing with coronavirus. We don't want to hear about your PLIF or your T10 to pelvis. You got no chance against them now. We were already over the barrel before. Tremendous economic pressure. Everybody on this call tonight is getting pressure from their hospital. Get back to work, don't travel, do more cases, bring in money. How exactly are we as spine surgeons going to juggle this act, right? And which of these are going to be long-lasting effects? A lot of people are assuming this is going to be very temporary. I will tell you that all 6 of these items will have a lasting imprint on Americans in the whole world, maybe more than a decade. So, spring of 2020, now is when doing surgery minimally invasive is really going to matter. So all my friends, and I do deformity, all my friends who say, I don't need to learn your shit. I do T10 to pelvis, get 140 RVUs. You're getting 30 RVUs. I'd be like, okay, fine. Okay, you go do your T10 to pelvis now. See what happens. You put your patients in the ICU with the coronavirus patients. Go ahead and do that. Yeah, see how that sells. And then put them in rehab where 47% of all deaths have occurred. So you're going to send your patient to rehab now, right? 47% of all deaths in America occur in rehab or nursing homes. So now you see the optics from the perspective of the patient. You're just trying to do a case, right? Now you have to realize you exist in a society. So let me show you a case. This occurred, we never really fully shut down, but for about 3 weeks in Miami, there was a situation where they said, you're not going to do any surgery except life-saving type operations or big ass brain tumors or people going to herniate, stuff like that. And I know in New York, you guys have been in this a lot longer, in Boston as well. This is a lady, English lady, who had seen me before the pandemic started. She was getting epidurals, kind of getting nursed along, private patient. I get a feed because now we had a lot of time, right? We're sitting around looking at our computers all day. I actually look into Epic, and I don't even like to read medical records, but I see this alert come through Epic. Suicide risk, okay? So I click it open. I'm like, geez, I got to look at this. It's this lady. I call her up. She says, Dr. Wang, you need to fix me now because I am going to go kill myself. And you all have patients like this. People who are so crippled that used to be normal. And she cannot walk to her bathroom anymore. And she's 50 years old, she's healthy. Her husband runs a huge lawn care business. They have a lot of money. And she's like, I'm going to kill myself, right? I'm like, okay, listen, ma'am, you don't have to kill yourself. So I take it to the hospital board. We have committees, right? So I got to do this surgery. I don't know how long this virus thing's going to go on, but we got to do this surgery. They say, well, how are you going to do it? And I say, oh, do a wake fusion. And it was like a rubber stamp. Boom, go ahead. And then the next case came up. Someone wanted to do a TLIF, right? They're like, why would you do that? You got to intubate the patient. You got to do all these things. We're not going to do that. Sorry, it's not going to happen. We don't have enough tests, right? The act of intubation now becomes threatening, right? So this is the case. I'll just show you real quick. Very simple. Anybody can do this case, right? But there are major barriers to adoption, right? Like how do you access? How do you get into these areas? How do you do this? I don't have an endoscope. All these things, right? So the positive side of this is technology overcomes all of this, right? It's very easy if the economics are aligned, right? And the thing about BMP, right? So all of these things are basically technical or political or bureaucratic barriers. They're not actual scientific barriers to advancement. So we switched to doing this stuff robotically. And if you look at the robots, these are all the robots that are out there. There's so many of them. I mean, these are exciting technologies. They're not all, they're not all mature. They're very expensive. But we realized that leveraging the robot might be the way to get around this. So if you take the 6 components we had together, and let's take away the awake anesthesia, because a lot of people say, look, I'm never going to talk my anesthesia group into that. And we replace it with the robot. So now you have the endoscope for miniaturization. You have the robot to be accurate and localized, percutaneous fixation for stabilization, Expandable for pain control, the expandables for distraction correction, and osteobiologics for arthrodesis, okay? You change everything. So this little video, and I'll just let it run if anybody wants to talk. You guys feel free to chime in. This video shows that anybody, and I have to be careful what I say because we're being recorded, right? I'm not trying to suggest that you can teach a monkey how to operate. Anybody with basic training can now potentially do an endoscopic, percutaneous, or awake for that matter, right? Fusion. It doesn't require 20 years of experience. I'm not saying you're going to be as good as someone with 20 years. What I'm saying is that in a pinch, it's going to change everything. Now, I know that there are a lot of orthopedic surgeons who say to me, where's the virtue in that there's no art left in surgery? There's tons of art. How about who to operate on? You know, how about taking the field further, right? But these little basic things, like how you put a screw into a body, if that's the definition of what you are, you're already extinct. Because if that's the only skill set you've got out there, forget it, you're done, right? Let the robot do what the robot's good at, right? Now, this is just Gen 2 robot. Wait another 10 years. Wait till we actually teach the robot how to do things even better. It's very, very threatening. It's existentially threatening to us, right? So I would say, well, just like Elon Musk, the only way to deal with the AI is to become part of it, to control it, not to fight it, right? And so this shows how you can basically, I can take anybody, and I'm doing one of these tomorrow, right? And they can, because what is scary is, where are you? Where's this thing going? How am I going to do this? The rest of the pieces are, let's say, relatively automated. Now, look, I'm still perfecting this, right? We've done lots and lots of cases like this. Let me perfect it. Let Ali Baj and Khoi Than and Griffin Baum and John Shin, let us get out there to perfect it if you're scared of this technology. But I'm telling you, I'll put my entire life savings on it. This kind of stuff is the future.
Hey,
go ahead.
Ali, sorry to interrupt.
No, go ahead.
This is, by the way, it's a great video. It's interesting. Just to, I think on Tuesday we had a special session here on virtual spine on augmented reality and robotics. So obviously it's a popular topic. A lot of people are interested in it. And of course, Ibrahim Hussein, our chief resident, who's going to be joining you in a few months, is like drooling watching this. But I have to ask a question that I'm sure is on a lot of people's mind, is this technology, which is obviously very expensive, like you said, it's still Gen 1, Gen 2. There's a lot of barriers to adoption. How does it change the outcomes? How does it change? I get the cost. I get that in a pandemic, hey, if there's another pandemic, the only people that are going to have surgeries are the ones that know how to do this. But how does this change the outcomes of the patients when compared to cohorts of, say, traditional or tubular fusions?
Yeah, I would tell you that at the most basic level, without trying to make the plea that it is more accurate, just the fact that you can standardize a technique means you're probably going to get better results. Because if you can standardize it, look at hip replacements. One of the reasons they do so well is they standardize it and they teach it. There's only a couple schools of thought for hip replacement, as far as I can tell. And if something's not working, everybody knows, and they rally together to fix that problem, right? And then new technology comes along, they vet it. They know pretty quickly, like, if there's some issue with it, because everybody's doing it the same way. In spine, it's always this battle between, I'm better than you, you're worse than me, my results are better than you, you suck, and nobody knows which results are the real results, right? And I have, by the way, I can give a whole talk on that because we've got new technology coming for this. I will tell you, though, last week we did, and I don't want to overspeak, the first in man robotic laminectomy. And that's a whole nother thing I can share with you. There's no question this is coming. It's expensive, I got it. I always show people that the first, the iPad 2 costs $190 a Target. Everybody's got an iPad. The iPad 2 in computing power going back only 60 years was $150 trillion. And if you go back 5 years, it was probably $1 million. So so you think about, well, okay, yeah, I got it. In 5 years, my talk's going to suck because it'll be so antiquated, right? But that's the indicator of its success to some degree, I think. And I know that's not a satisfying answer to everybody.
Yeah, no, I appreciate it, but I know it's on a lot of people's mind, weighing the cost versus the outcomes. Thank you for
that. Let me just, and I'll just take a stance on that, because I don't want to sound too much like a dictator, but I'm gonna take a stance on it. The average neurosurgeon brings their hospital something like $15 to $25 million a year. Okay, and the profit margin on that's probably on the order of $2 to $3 million, right? That's a normal average guy. That's not like you guys. Look, I get it. The hospitals want to make it sound like you're the bad guy, that you're the problem, that you're the cost center. And then when you stop doing cases, they're like, where were you? It's like a bad marriage, right? It's really hideous. And look, the robots are priced to market. It's not that, if they sell enough robots, they're not going to be $1 million anymore. Right now, they're like handmade cars, right? That's the problem. It doesn't cost $1 million to make a robot. The problem is they're not making enough of them. And that would be my plea, but again, I'm a new tech kind of guy. And I'm talking about high tech, biologics, and minimally invasive are the future. And this is just a summary slide about MIS TLIF. There's it's very versatile. We can treat a lot of stuff with it. You know, there's a lot of advantages. And I think this sort of ultra MIS, the ultra MIS, beyond just the 26 tube, is really where the future's headed. And we have a paper coming out about, it's called Size Matters, talking about, you know, people sometimes think if you do a MIS TLIF through a 16 millimeter or 24 millimeter, it's the same thing. It is not even close to the same thing. And when you get down to the diameter where we're at, like 8, it's quite different. It really is quite different. So, but you have to remember, our surgeries have to be measured against the gold standard. I am not in any ways proposing that this is superior to every other surgery. There's lots of limitations. There's lots of problems. And I'm happy to answer all those questions. It would be a whole 5 or 6 hours of discussion about what we've learned. Shameless plug for our neurosurgery podcast. We're about to pass 60,000 listens since our launch at CNS last year. Feel free to tune in. It's kind of fun. And we got to have you guys on, by the way. Got to have you guys on to this thing. So I think that's it. Yep.
Hey, Mike, I can ask some questions of you. If you don't mind keeping that up and maybe going back to your ERAS slide showing the different components, I think it might be worthwhile for the audience to really dive down into each of those. But before that, I'll have 2 questions for you. So first, that case you showed with the suicidal patient, you know, with pathology at 2-3, again, you know, I think totally get maybe some reluctance of doing, you know, 4 or 5 laterals because of, you know, the plexus, as well as, you know, higher likelihood of vascular injury there. Are you using lateral in any aspect of your practice right now?
Oh yeah, absolutely. I do a good number of laterals. I'm just not a, you know, because I had that first paper about thigh pain. That's one of the things, you know, I always have to debate anti-lateral because Blake Rogers said the rate of thigh pain was 0.1%. And I would get together with like Paul Park and Dean Chow, and they'd be like, seems like half the patients have this. And sure enough, it's 60%. And so there's just some level of dishonesty with the origin of that surgery. It's an amazing surgery. It's incredibly valuable. I use it a lot, but I always get picked on to debate because, you know, there are some super lateral devotees that are very financially well backed. And, you know, I don't want to get into that whole politic, but it's the reality, right? And so, you know, they're always going to look for the straw man. Nobody will go up against them. Nobody will go against them except me. So then I'm always pegged as the anti-lateral guy. I'm not anti-lateral at all.
You don't have to do that, Mike. I'll do that for you. I mean,
will you?
I'm somebody who trained with somebody who did a lot of laterals. I think there's a very, very good role for lateral MIS in certain cases. But there's no question, and I tell this to everybody, having done both and having the ability to do both, the results are certainly more reproducible, and it's, you know, posteriorly. And a posterior MIS TLIF is more reproducible, it's more reliable, and you're not going to get what I call the, you know, the unexpected complications that you can get with a lateral. I'll tell that to anybody having done both. So I think you're absolutely right when it comes to that.
Okay, you're on. You get to carry the mantle now for TLIF. I love it. Great.
Mike, let's talk a little bit about the endoscopic, you know, TLIF that you're doing. You know, so I think the arguments for the tubular, which is what I, you know, do 100% of the time, is, you know, probably better decompression of the neural structures, right? I think a unilateral facetectomy plus a discectomy essentially never encounter a spondy that cannot be reduced, right? So what do you have to say about that? And when are you, you know, not choosing to use an endoscopic TLIF?
Yeah, that's a great point, Coy. So initially, we're like, if they have complete loss of CSF signal at the level, we're going to do a MIS or open TLIF. We stopped doing that about 80 patients in, and we're at 260 now. So we stopped that about 4 years ago. So we take all comers, even people who are completely occluded. Now, that doesn't mean it always works. So with those patients, we explain to them, actually we tell all the patients, there's a certain percentage of people that are not going to get better enough with that. And so some people are going to have to get a formal decompression with a laminotomy, almost always delayed. It's almost always like a couple months later, they're not better enough, and we take them back. You've essentially divided the surgery into 2 pieces, right? One is the heavy lifting, which is the screws, rods, cage, and the other piece is the laminotomy. So of course that's not great because you have 2 anesthetic events, but I can tell you the percentage at which that occurs, which is 3%. So 3 out of 100 people have to come back at that level. I'll tell you, I did one this week. I did a lady who had a 2-level robotic TLIF, and she did great for 6 months. I don't know if she has a pseudo. She must. She got a disc herniation, just a little disc herniation at one of the levels. I've never seen it. We took her back. We did a microdisc. So is that preferable to having to do that on everybody? That's a very much a philosophical question, right? I'm actually of the belief, sorry, Coy. One of the things I'm trying to do with all this, and you can disagree if you want, anybody out there can disagree, is to divide the surgical event into a longer temporal time frame. So what the analogy I use is something like this. If you take your kid to the orthodontist, what they don't do is take a chisel, knock out all the teeth, and put in a bunch of implants. That would be the worst. What they also don't do is tighten everything up and straighten the teeth out in the next day. They put in the braces, and over the next months to years, they let the teeth do what they have to do. So if you could take a T10 to pelvis, which is a massive operation, right? I mean, you can get away with it all the time, but massive operation, and break that into 5 or 6 parts, and take a person through 5 or 6 outpatient procedures to get from A to Z, you could operate on a 100-year-old, right? If you could somehow do that. And if you're listening to what I'm actually saying, I'm not saying this stuff is better. I'm saying it's an incrementalist philosophy. You try to break it down, and that's the trend in a lot of things. If you look at cardiac stents versus bypass surgery, it's about trying to break the morbidity down into digestible pieces and into definable events. Each event is very small, and therefore you can stop at any point, or you could take them through all of it, but you have time on your side. So anyways, that's kind of a very, very long answer to a very simple question, because the answer is, you're right. I'm not doing a direct decompression in the way you are with the facetectomy and all that, right? Clearly not.
Mike, we have a couple of more good questions, but I wanted to see if any of our colleague faculty hosts had any. I want to make sure they get in their questions to you as well. Griffin, John, Wendy, or Jonathan, do you guys have any questions for Mike before I finish off with a couple of questions?
Yeah, Mike, I think, obviously we've got, sorry, I was muted, then unmuted, but, we've got a really international crowd. And so I think for, a lot of us, you've talked about a lot of technology, you've talked about a lot of, advanced stuff that you have, really pushing the envelope from the MIS perspective. If you can, imagine starting with nothing, no technology, no gizmos, no robots, no endoscopes, no anything. What would be the bare minimum necessary technology that you would need to start an MIS program, or to really try and start to help patients in an MIS fashion?
And you mean the implants are available?
Implants are available. I'm talking merely the reproducible technology that you use.
Okay, so any kind of implant, or just the implants that are available in China, let's say, or something like that?
I would say just not from an implant perspective, but more from a tubes, image acquisition, navigation, retractors, things like that.
The only thing you need is a fluoroscope. And I'll tell you why that's the case, and it sounds crazy. Because, when we went to Haiti and we fused all those people percutaneously and all that, that's all we had. It really, the trend is more and more towards having everything be disposable or packaged or whatnot. I think the fluoroscope is the one tool you can't live without in my world, because you can't navigate these scopes yet. I mean, it's getting very close to that. I can work my way around the other pieces. So we did another, I don't want to call it, it's not first in man, but it's definitely one of the first in man cases last week, which was an endoscopic separation surgery for metastasis. So that was crazy. And it would have been impossible without the fluoroscope. I think the fluoroscope is in some ways our eyes. It's going to be replaced eventually, but for now, the live imaging is very important. I know that's hard for people who don't like radiation, right? So you get some radiation. That's the cost, I think.
That's great. Thanks, Mike.
Dr. Wang, I'm a big believer in this. It's really phenomenal what you're doing. It's great to see the videos, and that was probably the first time I've actually seen it in action. So it's really awesome to see the OR workflow. Out of curiosity, from your experience, what do you think is the major barrier? What's stopping the widespread adoption of this technique and this procedure through most surgeons? What's stopping them?
Oh, I have a whole talk on that. That's like, did I give you that question? Thank you for the setup. Next week, we'll talk about, no, I'll tell you what it is, money. There is absolutely zero incentive right now for anybody to do what I'm doing. The only drivers, and I know we're being recorded, so I have to be careful because lawyers and patients may listen, but this is not, I'll just say it because it's true. Why did lateral take off? Well, it was powerful, gave people the ability to do MIS. They made more money. They had more billing codes. They build a front back. Now, if you're doing standalone lateral like I do, that's totally different. But if you're doing what most people are doing, which is a front back, they had to work around over 22612 and 22633 codes, which is the dissociation, the bundling of the PLIF, interbody, and posterolateral fusion. That was a 30% hit for surgeons. So being able to do a lateral or ALIF or whatever, well, guess what? You're making more money. And I'm just going to be honest, that is the driver. Money drives people. If you look at the CARES Act in the coronavirus era, it's all about money drivers. And that's what unfortunately happens a lot in a free market, right? People are going to do the things that pay the best and the patients do well with, of course. Patient care is always first, right? And so let me just get that out of the way. Of course, that's the case for us. For our panel, 100%. But things that cost you the least, time, effort, energy, radiation exposure, all that, whatever pays the most. And once you've figured that out, it's so simple to see why human behavior is the way it is. It's a horrible thing to say, right? I think I'm doing what's best for my patients. And I will debate anybody to the mat on this because I've spent a lot of sleepless nights thinking about these things. That doesn't mean I'm right. It doesn't mean that my patients do better than yours or that patient A will do better than patient B. We're looking at the aggregate, right? We're taking care of this panel people has probably done surgery on over 25,000 people, I'm guessing. Take every one of those people is unique. Every one of those people in that group is unique, right? So I think that, for example, not having an endoscopic code was one of the biggest barriers to people not doing endoscopy. Why would you ever do a procedure that paid less? Like it's the dumbest thing in the world. Who is going to do that? The only people doing endoscopy are the ones in surgery centers doing work comp or charging cash. Well, now it's immediately revealed. It's uncloaked, right? The Klingon vertebrae is uncloaked and you see it for what it is. And that is the answer. I don't care how much you want to argue about radiation, learning curve, it's irrelevant. It's all about money. Why is there no lumbar artificial disc done? It's not because it doesn't work. It actually really works well. Can't get it authorized. Nobody's going to do it, right? And that is and I know we're recording, so I have to be careful what I say. It's the truth. I'll stand up in a court of law and say that. It's just a fact.